Hi, my name is Christine. This is a presentation that our team, I'm one of the wound and ostomy nurses that we've created with the respiratory supervisors with Carl and Cliff to talk about respiratory device related pressure injuries and how we can prevent them. We've had quite a bit in 2022 and so far in 2023, and we want to talk about the different products we can use and the ways that we can prevent them from happening to our patients. Pressure injuries, they're a nursing quality driven indicator. This is something that nursing keeps track of and that nursing records to determine nursing quality care. But we wanted to partner with the respiratory team since you're the experts in airway and the experts in respiratory devices, that we can partner together to create better outcomes for our patients. So our objectives is we want to describe the main risk factors for PI development, identify the appropriate interventions different patients would need, and to demonstrate how to use Lyofoam and foam Mepilex Lite 5x5 dressings. So why is preventing respiratory device related pressure injuries so important? So for a couple of reasons, they all cause negative outcomes for patients. Any full thickness wound will leave a scar. So if a patient develops a pressure injury on their face, it's going to leave a permanent scar, which can be very unsightly and very upsetting. They can cause pain for the patient. They're expensive. They're all hospital acquired pressure injuries can cost up to $10,000. And that doesn't include any fines that the hospital might acquire. Pressure injuries are reportable to the state, and then they lead to poor outcomes and can cause wound complications for patients. So this is our incidence in 2022. We had 43. The devices that were involved were the trach tie, trach plate, ET tube fasteners, ETT tubes, non-invasive ventilation masks, so CPAP and BiPAP, and then CPAP tubing. That was a case of baby in the NICU. The CPAP machine was behind their head and the tubing was laying on their forehead, and just that was enough to cause them to get a pressure injury on their forehead. And then this is the locations of where these PIs occurred. So the trach tie was to the neck, the trach plate was to the midclavicular notch, which is right here on the neck, below where the trach would be. 9 were from ET tube fasteners on the zygomatics on the cheekbone. There was 1 on the philtrum, which is the upper lip. 11 were related to the ET tubes themselves, and they were in the on the lips and the inside of the lips. And then 14 related to CPAP and BiPAP masks, and those were mostly on the nasal bridge, the nostrils, and then the nasal septum. And then we've had 10 so far for 2023, and they've been CPAP and BiPAP masks, ET tubes, ET tube fasteners, and 1 from a bite block. And these are the locations of where they occurred: the nasal bridge, the lip and the tongue, the cheekbones, and then the upper lip. So this is a breakdown of the units where they happen. So obviously our patients are much sicker in the ICUs. So there are more than the ICUs than there were in med-surg units. 4 South had the most, followed by 5 South and 8 South. And then so far for 2023, 5 South has had the most, 5 South has had 6 so far for the year. And then in step downs and med-surg, we still are, they're still happening there. But just less, 14 South had the most in 2022. And this has excluded any nasal cannulas. We've had quite a bit of people get pressure injuries from the nasal cannulas, but all these numbers are excluding anything like nasal cannulas, because that's not something that your team would be following. That would be more nursing. So these only include devices that respiratory team was managing. So CPAP, BiPAP, ET tube fasteners, ETT tubes, things like that. So how do respiratory device-related pressure injuries develop? So it's from pressure, the pressure of the device against the skin and the underlying tissues. So the major contributors of pressure injuries are pressure, friction, and shear. So a device rubbing back and forth, and then moisture. And they usually occur over a bony prominence. And this risk increases when a device is on a bony prominence. So when most people hear pressure injury, they think of on the sacrum, they think of a patient that's been laying in bed and they get a pressure injury on their backside. But now these are on the device, and these are on the face where the respiratory device was sitting on their face and putting the pressure. So instead of the patient laying in bed and their sacrum, their tailbone being against the mattress and the pressure from that, this is the pressure from the device along their face. The skin on the face is very thin. In the next slide, we're going to talk about the facial anatomy a little bit more, but the pressure from the device and then the bone against the bone, it causes the skin to break down. And we can see from this picture here of the skeleton, this just shows all the bony prominences on the face. And we always want to prevent, because it's much easier to prevent than it is to cure these pressure injuries. So the skin on the face is the thinnest place in the entire body. The skin thickness is only about 2 to 3 millimeters on the face. There's not that much muscle or fat protecting the face, between the face and the bone on the between the bone and the skin on the face. There's less fat tissue and there's less muscle to act as a cushion. I know I'm just touching my nose right now and I feel my bone, it's right there. In other parts of the body, people have much more protection from pressure. And then a lot of our patients that are critically ill in the ICU, they're edematous and they're swollen, and that causes the skin to stretch, almost like we're stretching a piece of saran wrap. And then the skin is thinner and weaker and can break down easier. And then you add a device into the mix, and that just causes them increases their risk of breaking down. And then if these patients are altered or sedated, they're not able to communicate and let them know that it's starting to hurt, or they're starting to feel that it's they're starting to feel the pressure, almost like if you were wearing an uncomfortable pair of shoes and you felt the pressure, you felt the friction or shear, you would know to take them off. The patients can't communicate that, hey, I think I need this device repositioned because it's hurting me, because they're unable to do so. So we're going to talk about staging. So this is not a responsibility of the respiratory team. We're not asking you to stage pressure injuries. We're not asking you to do wound treatment, but we just wanted to let you know the different stages so that when people are talking about it, so you're aware, just so you are all, so we all are aware of the different stages. So stage 1 pressure injuries, this is just intact skin that with non-blanchable redness. So it doesn't blanch, it doesn't become lighter when it's touched. It stays red. So there's no open skin yet. There's no breakdown, but there is damage that's done below the skin surface. So it's almost like if you had your knees crossed on a hot summer day and you get a red mark on your knee, and then if you touch it and your capillary refill would return, and the your skin would bounce back and the redness would go away, it would become lighter when you touched it. With these patients, with the stage 1, it would stay red even when you touched it. And this can be harder to identify in patients with darker skin. So we always want to make sure that we are assessing our patients in good lighting. And it's important to palpate the skin, because a stage 1 might not look red, but it might feel cooler or warmer to the touch, or it might have a boggy feeling to it. So this is a picture of a baby that had a device on his face, and there's just, you can see that intact redness that's to their face. There's no open areas, but it's just very, very red. This can continue to break down much easier. This is almost like a warning sign, because if someone put the device back on their face and their skin is already red, it would likely break down and get worse. So this is like letting us know that the skin's getting a little too much pressure on it. If we were to touch that baby's skin, it would stay red. It wouldn't, the color underneath wouldn't return to us. So then after stage 1, we have stage 2, 3, and 4, and I've clustered them together all in the same slide because they're all going to present very similar on the face. So stage 2, 3, and 4, they're all open wounds. There's all tissue underneath the skin surface is exposed. On the buttocks, on the sacrum, a stage 2 would look very, very different from a stage 4. A stage 2 on the sacral area would just look like the skin off of a tomato, just like that first layer gone. And then a stage 4 would go all the way down to bone. So on places on the body where there's much more fat tissue, where there's much more muscle, it would appear very different. But on the face, where there's not much protecting our patients between the bone and the skin, they would all look the same, because they'd be have little thickness, but they could be down to the bone as well. So a stage 2 would present with pink, moist, red tissue. A stage 3 might have some scattered areas of fat tissue, some subcutaneous tissue showing, and then a stage 4 is down to the bone. So this picture on the far right of the patient's nose, even though it looks very thin, if you see that, you might be like, oh, that's just the top layer of skin gone. That doesn't look too bad. It does go all the way down to bone. So this patient likely had a CPAP or a BiPAP mask on, and the pressure from that against their nose is what created that there. And then the other picture, that's a patient with a pressure injury to their midclavicular notch from their trach plate, from the pressure of the trach plate against their skin. And that also doesn't look very deep. It looks very superficial, but because of where it is and there's not much protection, there's not much tissue to protect it, it's considered a full thickness. So again, not responsible for staging. You won't be responsible to identify if a wound is a 2, 3, or 4, just to know that it's open and that it is a wound or is a pressure injury. So deep tissue pressure injuries, these are a little different, where the skin is intact, but so there's no open areas, but it's deep purple maroon. So these kind of present like a deep bruise, but there's no diffuse edges. It's much more purple than brown. And it's almost like an iceberg effect, like we can see in this cutaway picture on the right, where it doesn't look that bad on the top. It just looks like some intact purple skin, but the damage goes all the way down to the bone. And these wounds, they either fade away, luckily if we catch them soon enough and we can change the device, or if it's on their buttocks or another part of their body and we get the pressure off, usually they fade away. But sometimes that doesn't happen and they open up and they evolve into become a full thickness wound. Sometimes all of that tissue just changes and becomes fully necrotic or like devitalized, and then it becomes an unstable pressure injury, which we're going to talk about in a minute. Sometimes the top layer of skin kind of peels off, it kind of gets fragile and peels away, and then there's a full thickness wound. So this is what they look like. So yes, more purple than brown, and a little bit different than a bruise. It's usually the edges is where you can really tell that it's a DTI and not a bruise, how they look very, very intact. And this picture shows a progression of how a DTI can change or evolve. And this leads us into unstable pressure injuries. So this is when we can't say how deep a wound is. We can't stage it because we can't see the wound bed because it's obstructed by necrotic tissue. So this picture on the far right, that shows the breakdown of it. There's a wound with some black eschar and then also some white moist slough tissue. And from the top of the surface, it doesn't look that bad. It looks just like surface level brown tissue, but we can't see how much damage is done underneath. It looks like this one goes all the way down to bone. And then this is a man's face that he must have had either a CPAP or a BiPAP mask on, and all it's leathery black eschar on his face. It looks different than a scab. All a scab is just dried serous exudate, just like dried clear exudate. But this is different. It's like leathery and dry, and we can't see what's underneath it. It might go all the way down to bone. The last stage we're going to talk about is mucocutaneous pressure injuries. So these are pressure injuries that happen on the mucosa. So mostly on the lips, on the inside of the lips and on the tongue. So those aren't bony prominences, but they still can get pressure if devices are on them. So we'll see quite a bit on the tongue or on the inside of the lip, and that these are mucosal membrane pressure injuries and they don't get staged because they don't see the similar damage as the other pressure injuries do. So completing a skin assessment. So we're asking the respiratory therapy team to complete a skin assessment when you're applying a new device, when you're removing a new device, changing a device, during trach care, and at the end of each and during each shift, the skin should be assessed. And we want the skin to be intact without redness. Blanchable redness can be an indicator of a developing pressure injury. If it looks red and you touch it and the skin bounces back, but it's still red. So these should all be reported to the nurse. So any kind of skin alteration you see, whether if you think it's pressure related or not, you want to report that to the nurse, and then they'll escalate it to us. And if we get a new admission and they have a pressure injury, we have 24 hours from the time they walk through the doors for us to document it. So there was an incident last year where there was a patient that we had a feeling they might have come here with the wound, but it wasn't documented, and then we end up absorbing it as a HAPI. So in this first picture, there's just like it looks like a shallow wound, depending on where that was or what device was over it. It might be related to pressure. And then these are some pictures of skin that's related to moisture. It's damaged from moisture. So all of these you'd want to report it to the nurse, and then they'll report it to us. So documenting skin changes. So this is a screenshot of the notes that you write in Epic, and there I have the arrow, the blue arrow near where it says skin breakdown, and for this patient it says no. So you'd want to, if you do see skin breakdown, you just want to describe what you see. Again, you're not responsible for staging, but you can just kind of say, I saw it open and there was red moist tissue. I saw it and there was black dry tissue. Just to write what you see, and then that you want to also tell the nurse and then indicate which nurse you told. And then the nurse will do their assessment, and if they believe it's a pressure injury, then they'll escalate it to us so that we can come by and give recommendations. And if you ever want to look through our notes, or if you ever just want to see if you see something on the face, if you see a wound on the nose, and if you're not sure if this is something new or if this is something that's there already, this is where you can check. This is the LDAs in the nursing chart. This is under the avatar. And this is pointing that there's a pressure injury documented, a DTI to the mid-nose. And if you click on that, what opens this up is on the right. This is called the properties of the wound, and this describes just a little bit more in it. And there's this patient, it was indicated that it was respiratory related from a CPAP and BiPAP mask. And the nursing staff is the one who enters the LDAs. They enter them through all pressure injuries, and including the ones that are related to the face or respiratory devices. If you ever want to look at our notes, or if you're not sure if we've seen them, or if you want to try to find our notes, this is how you can just find us If you go to service, we're always on the, and then minimize all of the notes. You can see all the different notes that have been in by service, and we're always on the bottom just because it's alphabetical order, wound and ostomy care. And then this is what our notes look like. We first give a description of what the wound looks like. So this patient, he had a medical device-related unstable pressure injury to the mid-nasal bridge from a BiPAP mask. And this just describes it. And I had said that there was 100% dry, intact, adherent black eschar. It's like dry, leathery tissue. And then under what we can't see is because it's unstable. Underneath that, the damage might be much worse than underneath. This patient also had a DTI to the sacrum. We don't have to worry about that. We're just concerned with the respiratory device related pressure injuries. And then it's listed under the impression, and then we have the treatment plan on the bottom. So it's not respiratory's responsibility to do the dressing treatments. The nursing does this, but this is it's just explaining to you just in case you want to find it yourself on where to see the note. So now we're going to talk about prevention, and we're going to go by device. We're going to talk about all the different devices that we use here. So for tracheostomy-related PI prevention, we want to use the Lyofoam. I have a picture of it in the right upper corner, and I also have some here with me here. It's like a foam dressing that has a hole in it, and then we wrap it around the trach plate. It's really good because it helps with all three parts of pressure injury development. Pressure injuries happen from pressure, and this is a cushion, so it's separating the trach plate, the plastic trach plate from the skin. It helps reduce friction and shear because the trach plate will be rubbing on this rather than on the patient's skin. And these are really good at managing exudate and drainage because they absorb quite a bit. They'll kind of swell up like a little sponge, and you can put this around your patient's trach. And before you do this, we're recommending that you take Cavalon, a no-sting barrier film. I have the picture below. It's like a liquid Band-Aid, and you'd want to apply that to the area around the trach site first. And it provides an invisible layer, and then you can go ahead and apply this on over it. To put this on, you kind of just pull these pieces apart and then wrap it around the trach plate and kind of shimmy it into place. So we've seen a lot of people use gauze along with these. We'll see people take a split gauze and put it on top of this, and that isn't necessary. That actually increases the tension and pressure. And if there is an increased amount of exudate, you can tuck a piece of Aquacel AG. I have it right here on the screen, and I have some here with me as well. This is like a fabric-like dressing where it absorbs, it kind of gels up when it gets wet. This is what it looks like. You can just tuck this underneath and put it under the trach plate, and then put the Lyofoam on top if they're really making a lot of drainage. And this helps prevent pressure injuries to the midclavicular notch here where the sternum and the clavicles meet. So if the sutures are still intact, this poses a problem because then we can't fit the Lyofoam underneath the sutures. So if that is the case, if your patient does still have sutures in place, you can cut a little piece of a Mepilex Lite dressing. You can cut it into a little strip and then lift the patient's neck up if they can, and then slide this underneath as far as you can. And this won't wrap fully around the trach plate, but this would offload just that little bit on the bottom. This is a bedside tracheostomy checklist. This was created by our colleague Lisa in 2020, and this should be at the bedside of every patient with a trach. It should be initiated by the RN for all new patients with the trach, and then for patients who were admitted with the trach. And this allows communication between the surgical team, RT, and nursing staff, and it stays with the patient for all of their transfers. I have a link there to where to find it on the InfoNet if you're interested. And there's also a portion that talks about trach sutures. So trach sutures are to be left in place for 7 days. If trach sutures are in for longer than that, you'd want to escalate it to the RN so that they can notify the team, because trach sutures aren't supposed to be in for longer than that. And we've all seen them stay in for extra time that's not needed. And the unfortunate news, I know a lot of us love the Lyofoam. It's going to be discontinued probably in the next month or so. We still have it for a few months, and I'm going to talk about the new slide in a minute, but the new product was created after his feedback that the Lyofoam Max didn't absorb enough. People felt that these got too saturated still with trach secretions, so we're going to continue using it at this time until further notice, until the new product comes. And we'll update you once we know, once the Lyofoam is phased out, once the new product comes, we'll let everyone know. So the new product is called Mepilex Up. I have the picture of it here. So it the advantages that it has is that it absorbs more than Lyofoam. Our vendor came and showed us. She poured like a whole cup of coffee over one of these and it was able to absorb it much more. So it's good for the trach if your patient's really having a lot of secretions. It keeps the skin drier and it's a better management of moisture. But it's very similar to the Lyofoam T, the Max, in a lot of ways, is in the sense that it can still also offload pressure, reduce friction, and in addition to absorbing the exudate. And the application is the same as a Lyofoam. The only difference is that it doesn't come pre-cut, so you just need to cut a little slit in it and then to wrap it around. I have pictures on the next slide demonstrating that. So you want to make sure the skin is clean and dry first. You can use the Cavalon Skin Prep, the liquid Band-Aid to apply over to the skin around it to keep that dry and protected. And then cut a 2-inch slit halfway through, and then you can wrap that around the trach, just as you would with the split gauze and just as you would with the Lyofoam. If you were to cut these, they wouldn't pill and open up, like it would all stay together. The Mepilex wouldn't get damaged because nothing would go inside the trach. What you don't want to do, this is a regular Mepilex dressing. You might see these at the bedside. We use these on the patients on all parts of their body. These ones have a border along them. I'm sure you can see that in the screen, this little like 1 inch on the side. This is a border. So bordered Mepilex like this one can't be cut. I just cut this one for demonstration. And what can happen is that the insides can kind of pill out and come out and make a mess. And we don't want that to happen. So these ones with the border can't be cut. If you see a Mepilex dressing without a border, it can be cut and you can cut into different shapes and sizes that you need. And then this would go around the trach plate. And it's also has an adhesive on the backing that you'd want to remove first. You don't want it to necessarily stick to the skin. It's not super sticky or super like tacky, so you can just still wrap it around the trach plate. You would want to take off the wrapper on the back first. So Mepilex Lite 5x5, the preventative foam dressing. So this is a new product that's coming out. I have the product guide on the bottom right here. This is, since the major causes of pressure injuries are pressure, friction, and shear and moisture, we want to use a foam dressing under a lot of our respiratory devices to cushion the face and offload that pressure. Foam dressings provide a better barrier protection between the mask and the skin. And if the patient's moving around a lot, the mask will rub on the foam, not the face, which eliminates friction and reduces pressure. So the Mepilex 5x5 can be used under CPAP and BiPAP masks, under high flow nasal cannula tubing, around the ears for patients on nasal cannula. Again, I know we talked about this before. This wouldn't be an intervention done by the respiratory team. This would be from the nursing staff, but this is just so that you're aware in case you see someone that you're taking off of one respiratory device and putting on a nasal cannula. It might be worth mentioning to the nurse. And it can also be used under other devices. Additional features, the cutting guide on the back. This is really great. This is almost like when kids fold paper in different ways and then make little cuts and then they unravel it and have a snowflake. It's kind of the same concept here. So this is the new Mepilex has a cutting guide on the back, as you can see. And I have here with me one that I cut already. So you can fold it in half. And I like to think that the word purple begins with the letter P and the word PAP, as in CPAP and BiPAP, begins with the letter P. So you can fold it and then you'd want to cut along the purple and then you get this mask shape that you can put over the patient's nose and forehead. Over the nose and forehead to prevent pressure injuries when they're on the CPAP or BiPAP mask. So it can stay on for 3 days, but it still needs to be lifted and assessed each day. And you want to label and date it when it was applied. So I have this labeled over here. And we still have the protected gel in place, but we're moving towards using the Mepilex Lite instead. Just because it's preferred, we find it's easier to apply and it stays on better. So you just cut this and then you peel off the backing and then you can apply it to the face as needed. And you still just want to peel it back every day when you're doing your every day to make sure the skin is intact still. So the former Mepilex 4x4 that I have right here, it doesn't have a cutting guide. This is what we're using before. There's no cutting guide on the back, so we can't, if you see this still, you wouldn't be able to fold it and cut into the shapes. There's no pre-cut line. There's no dotted lines telling you where to cut. So this one doesn't have that. And we wouldn't want to use the one with the border here because the opening can come out and pill all over the place and make a mess and possibly get into the trach. So we only want to use the one without a border. So to prevent CPAP and BiPAP mask related pressure injuries, you'd want to cut the Mepilex 5x5 into the mask formation. And then this would get applied to the face before the CPAP or the BiPAP mask is applied. And we'd want to initiate it if we're anticipating the use of non-invasive ventilation for more than 4 hours. And you want to stabilize the patient first, and then you can always apply this once the patient is more stable. If somebody can't breathe, obviously take care of the breathing first, and then we can worry about the skin afterwards. But if they're going to be on it for more than 4 hours, they definitely would need to have this preventative dressing on for them. And when you're doing the assessment, you want to lift one corner so that the skin can be assessed, and then it can be reapplied. If you want to look at the skin, you don't necessarily need to pull this all off. You can have this in place and just lift up a little bit that you need, and it would still go back and still stay sticky. And we want to just apply this to clean, dry skin. We want to avoid the use of using Cavalon skin prep around this, because it's just not needed, and it's sticky enough, so you wouldn't need any Cavalon in this situation. So purple, I think purple begins with P and PAP begins with P, so you'd want to fold it and then cut along the purple side. So just with my cursor, I'm just going to show you, while this is folded, you cut along this line and then along here, and then you develop the shape that can be put onto the face. So now we're going to talk about mask use and rotation. So this is the list of the 3 most commonly used masks that we have here. I know Carl said that we don't use the total mask unless it's absolutely necessary, because it can cause patients to become claustrophobic. But you'd want to rotate every 4 to 6 hours between the full face mask and then the full face mask that goes under the nose. And you'd want to do this for patients that are on continuous non-invasive ventilation to help offload the pressure as well. Because if you're still using the same mask constantly, there are patients at a higher risk of getting a pressure injury. But if you switch off the mask, that can kind of give the patient a break. So now we're going to talk about leak monitoring. So the manufacturer's algorithm feature designed to help monitor mask to patient interface and help reduce skin injuries associated with friction, tightness, and improve patient comfort and compliance. So leak monitoring less than 10 LPM means the mask is too tight. The optimal patient leak is greater than 10 LPM and less than 25 LPM. So we want to be between 10 and 25. But leaks greater than 25 is okay, as long as the set pressures or parameters are being achieved, and patient compliance and delivering targeted therapy is the goal of practice in leaks. So now we're going to talk about preventing high flow nasal cannula related pressure injuries. So the 5x5, it can be cut into strips. So I know we said P purple for PAP, but if we cut it in the other direction, we can get these strips like this, and that we can put on the face and on the cheekbones, under where the high flow nasal cannula would be, especially on the face, so they don't get pressure injuries to their cheekbones. And if you have a patient with a smaller face, you can always take the same shape and trim it up more if it will fit on the face better. And you can, again, assess them. You'd want to assess the skin each shift. You'd want to peel this back and take a look. And you eventually want to change the Mepilex if it doesn't stay sticky anymore. And then this is just showing more details on how to cut it. You'd fold it and cut it along the thin dotted lines, and that's when you get the 5 separate pieces that can be applied to the face. So now we're going to talk about ET tube fastener related pressure injuries. So we've seen quite a bit of patients get pressure injuries on their cheekbones from the ET tube fastener, especially if they were proned. So it's not recommended to use the Mepilex Lite with the ET tube fastener. I know it seems like, oh yeah, this is so light, this would fit right on the face, and we can put the fastener on top. But you wouldn't want to use them together. You don't want to use anything under the face. You can, it's like a ceramide dressing, and it can go straight onto the face. And then the ET tube fastener, it's designed for patients with tube sizes 5 to 10. And then you want to make sure that we're putting the ET tube fastener in the proper direction. There's some pictures here on the bottom that's showing how to make sure you have it not upside down. So you want the little white like checks to be facing up, like in picture 2 over here. Make sure we have it in the right direction. And after you apply it, you want to hold the adhesive pads for 30 seconds. The temperature will help attach the adhesion. And you want to make sure that the securement straps that go around the neck, they should be loose enough to pass 2 fingers through. They don't need to be too tight. If it's pulled back too tight, that can lead to pressure on the face and cause pressure injuries. And now we're going to talk about ET tube fastener prevention a little bit more. So the RTs, they change the fasteners every 72 hours, and the RT should assess the skin when they're changing this, and they should notify the RN of any discolorations or skin breakdown if it's noted. And we think a lot of the pressure injuries over the last year may have had a MARSI effect in them. MARSI stands for medical adhesive related skin injuries. It may have been damage from peeling or stripping the skin away. And so we want to make sure we're using adhesive remover when we're changing these. This is a little picture what the adhesive remover looks like. They have it, I know, in the ICUs. They have it in those drawers in the hallways. It's also in the clean supply rooms. It's, if you can't find it, it's usually near the ostomy supplies. And there's like a wipe on it, and you can use it to wipe around, and it loosens up the glue and will make the ET tube fastener come off much easier. And now we're going to talk about ET tube mucosal membrane pressure related pressure injuries. So it's important for the respiratory therapist to rotate the ETT tube each ventilator assessment. They'd want to document left, right, center, and document it on the ventilator flow sheet, which I have a screenshot of here. And you want to report any changes of the mucosa to the RN. And if facial hair is an issue, the respiratory therapist will attempt to use the slim fit Hollister. So this is a little breakdown. I know I just gave you a lot of information. This is a little breakdown of the different products that should be used for the different patients. So if the patient has a trach, we should use the Lyofoam with the Cavalon. If they have the trach, but the sutures are still in and we can't get the Lyofoam to fit, you can use it with a little piece of Mepilex Lite. We'd want to use the Mepilex Lite under CPAP and BiPAP masks, under high flow nasal cannulas, and then just information on how to safely remove the ET tube fastener and then to rotate the ET tube. And once Mepilex Up comes, once the Lyofoam is phased out, I just have the same thing with information about the Mepilex Up added. So just to summarize what we talked about, so we want to notify all skin changes to the RN, the primary RN that has the patient, rather than calling our team. We're not always here. We're not here on the weekends. We're not here overnight. So it'd be best to contact your nurse, and then they would know how to reach us, or they would know how then to document it. We want to use the Lyofoam underneath the trach plates. We want to use the Mepilex Lite under all non-invasive ventilation masks and underneath the high flow nasal cannula. We want to use adhesive remover when we can to remove the ET tube fastener, and we want to rotate our ET tubes. So wound treatments are not to be done by the RTs. That's all to be done by nursing. So applying Lyofoam, applying these preventive dressings is not wound treatment. This is just applying prevention. And we want to defer all wound care to the RN. And that was it. Thank you for following along and watching. We're going to be doing rounding and checking compliance. If you have any questions, these are our emails that you can reach out to us. Thank you.